Thank you, John. Thanks for the invitation to be here with you today. Indeed, I'm going to talk about CNS lymphoma, specifically primary CNS lymphoma today. Start with some definitions. We're going to cover the top one here. Primary CNS lymphoma is an extranodal non-Hodgkin lymphoma confined to the craniospinal axis without any evidence of systemic involvement. So this could be the brain, it could be the eyes, it could be the CSF, or rarely it can even be the spinal cord. That's in contrast to secondary nervous system lymphoma, which is much more common, which occurs when an established systemic lymphoma, of course, disseminates to the nervous system. And about 2/3 of the time, that's the leptomeninges, and about 1/3 of the time it's into the brain parenchyma. If you look at other forms of extranodal diffuse large B-cell lymphoma, you can see here that diffuse large B-cell lymphoma in the brain has the worst prognosis of any of the other organ types. So we really are lagging behind in terms of treatment of this entity. This is an H&E slide showing a unique feature when diffuse large B-cell lymphoma occurs in the brain, and that's the angiocentric nature or pattern of the tumor growth. In the center of the vessel there is a cerebral arteriole, and around it you see these clumped malignant lymphocytes, and some of them are actually infiltrating the neuropil around it, but they clearly are clustering around the blood vessels, and that's a unique feature when it occurs in the brain. So a few words about pathology. When lymphoma occurs in the brain, more than 90% of the time it's diffuse large B-cell lymphoma, and of those, almost all of the time it's the ABC immunophenotype, which could very well be accounting for some of the inferior prognosis relative to other forms of systemic diffuse large B-cell lymphoma. And recent studies using whole exome sequencing have demonstrated that more than 90% of primary CNS diffuse large B cells have activation of the oncogenic toll-like receptor signaling pathway, or BCR activation, which would suggest particular targeted therapies to test in this rare disease in the future. I'll come back to that at the end. In terms of epidemiology, this is a rare malignancy. Estimated between 2007 and 2011, about 1,400 cases every year diagnosed in the United States. Clearly, the incidence increased in the 1970s and 1980s, but that began to plateau, and that was largely driven by the HIV pandemic. There is some evidence from SEER data that in the elderly, the incidence continues to go up slightly even now. In terms of demographics, median age at diagnosis is 60, slightly more common in males. It's a rapidly progressive CNS syndrome usually. In one study, the median time or average time from the first symptom to the histologic diagnosis is under 3 months. And if you look at what patients present with, they usually present with some combinations of neurologic symptoms and signs, but the most common symptom or sign has to do with mental status changes, often noticed by a family member. The International Primary CNS Lymphoma Collaborative Group, or the IPCG, has established baseline evaluation criteria when encountering these patients. This paper was published now more than 10 years ago, but we have an updated manuscript that is nearly ready for publication. So this will be updated slightly, but they're not major changes. Obviously, a clinical evaluation, including examination, medical and neurologic examination. The IPCG also has a brief cognitive battery that is recommended for all of these patients at baseline and subsequent testing. Prognostic factors are collected, of course, age, performance status. In terms of laboratory evaluation, HIV to make sure that this is a non-HIV related lymphoma, LDH, and if you're going to use methotrexate, assessment of renal function. We don't technically do staging because there's no staging system that correlates with prognosis in primary CNS lymphoma, so we call it extensive disease evaluation. Contrast-enhanced brain MRI is the gold standard for imaging. When safe, we advise a lumbar puncture to obtain 3 tests really, cytology, flow cytometry, and PCR, to determine if the disease is active also in the leptomeninges. Every patient should see an ophthalmologist and have a slit lamp examination. Anywhere from 10 to 20% will have concurrent involvement of the uvea or the retina, so it's important that they see an ophthalmologist. And of course, all patients should have body imaging, bone marrow assessment, to make sure that this is a primary CNS lymphoma and not a secondary CNS lymphoma. This is a classic appearance on a CT scan of a CNS lymphoma. So this is a patient who presented in the emergency room at our hospital with difficulty walking and headache. And this is before contrast is administered. This is after contrast is administered. You see this homogeneously enhancing mass deep in the brain, in this case in the splenium of the corpus callosum. And the patient had an MRI about an hour later, still in the emergency ward. And you can see the increased fidelity of MRI in picking up the extent of disease, because here's disease actually extending beyond the corpus callosum out into the parietal and temporal lobes. So again, MRI is the gold standard for imaging these patients prior to therapy and during therapy. If you look at sites of involvement, basically in the brain it parallels blood flow, no surprise. You have more disease in the frontal lobe than any of the other lobes. About 40% of the time, patients will have the classic deep location, just like I showed you, corpus callosum, etc. In the immunocompetent population, 2/3 of the time it's a single lesion. In the immunocompromised population, HIV post-transplant, about 50% of the time patients have multifocal disease in the brain. In this particular series, ophthalmological evaluation was done. 13% of the patients had concurrent disease in their eye, and 16% of patients had concurrent disease in their CSF. So that points out again the importance of assessing all of these compartments before you start treatment, because you have to assess each of these compartments moving forward to make sure that you achieve remission. So I'll switch gears and talk about treatment now. We have a couple of prognostic scales we use. One was developed by the International Extranodal Lymphoma Study Group. The IELSG looked at a number of features: age, performance status, LDH, blood LDH level, CSF protein level, and site in the brain. Bad markers being older age, compromised performance status, high LDH, high CSF protein, deep location. They had a complete data set and over 100 patients of all of these, and you can see if you had 0 to 1 of these negative markers, you had a 90% 3-year survival. If you have 4 to 5 of these markers, you have a 0% 3-year survival. So it really does stratify patients. Problem is that requires a lumbar puncture, CSF protein, and not every patient can have that. So a subsequent version of a prognostic scale was developed by the group at Memorial Sloan Kettering, Lauren Avery, when she was there, simply looking at age and performance status. And looking at age and performance status, you can clearly divide these patients into 3 prognostic groups. And this scale is the one that's been widely adopted and used in clinical trials, especially randomized clinical trials where we're stratifying by their prognostic score. The other thing that the IPCG has published is assessment guidelines. So I will not go into detail here, but this is the paper again from 2005 in the JCO. Again, this is a multi-compartmental disease, so you have to assess each compartment. So brain imaging, brain imaging, eye assessment, CSF assessment. And basically patients are categorized based on their response in each of these compartments. Okay, on to treatment. So a word about dexamethasone or steroids. You all know these are lymphotoxic drugs. They're included in many of your regimens. And in fact, steroids alone will induce radiographic responses in up to 40% of patients with primary CNS lymphoma. These are usually partial or minor responses. Turns out this is a good prognostic marker. The problem is, however, that if these are used before a biopsy is performed, it can be disruptive to the morphology of the cells, et cetera, make it very difficult for your pathologist to make a diagnosis of lymphoma. So they are to be avoided, if at all possible, before a biopsy. And it's really a rare patient who needs emergency treatment with steroids with this disorder. Okay, I'm going to focus today on randomized trials, and we're in a fortunate position that we are finally deriving treatment information from randomized trials in this rare tumor. This was the first successfully executed randomized phase 2 trial in CNS lymphoma. It was done by the IELSG again, and it was a very simple question, the induction chemotherapy question. Methotrexate alone versus methotrexate and Ara-C. And then all the patients went on to receive whole brain radiation. This is so-called combined modality therapy, chemotherapy and radiation. And if you can squint and see that the complete remission rate after chemotherapy, not surprisingly, was much higher in the patients who received the combination of methotrexate and Ara-C. And if you actually go over here and look at failure-free survival and overall survival, those patients initially receiving the combination of methotrexate and Ara-C had improved failure-free survival, improved overall survival. The next step, I'm sorry about the graphics there, but the next step was to ask, that was an induction question. The IELSG then asked a subsequent induction question and a consolidation question. So this is the IELSG 32. Partial results of this trial were just presented in Lugano back last June. And basically, patients, there was a double randomization. So patients newly diagnosed were randomized to what they now consider the standard, based on that earlier study, methotrexate and Ara-C, versus adding rituximab to methotrexate and Ara-C, triple drug therapy, versus rituximab and thiotepa added to methotrexate and Ara-C. This is the so-called matrix arm here. The primary endpoint here was radiographic response, and then patients were then randomized a second time. Those who had stable disease or better were randomized a second time to whole brain radiation versus a transplant. So at the Lugano meeting, they presented their results from the first randomization. So this is the 3 different arms. This is the matrix arm, 4 drugs, 3 drugs, 2 drugs, and you can see that there is a significantly higher complete response and overall response in the matrix arm, the 4-drug arm. They also showed that this benefit appeared to be the case for all 3 of the risk groups, the prognostic groups. They also showed that the matrix patients could have successful subsequent stem cell collection. So this was a positive result in the first part of the study. Now they presented their preliminary results for progression-free survival and overall survival, but it's really premature to make any judgment of this because remember, there's a second randomization, and some of these patients got whole brain, some of these patients got high-dose chemotherapy and transplant. So we really have to wait for the final results of the study to know whether the PFS and overall survival outcomes. So I've been talking a bit about combined modality therapy. One of the problems we encounter in this patient population is that our target is the brain with these drugs and radiation, and we end up with a fair amount of neurotoxicity in these patients. And this is an example of such. A patient of mine who had been treated elsewhere with whole brain radiation, by the time I encountered him, and he comes to me with neurologic symptoms and signs, thinking that he had a relapse. This is his MRI, and you can see this is where his prior tumor had been, and there's just a cavity there. And basically, he's got all this abnormal signal in his white matter. He's got a lot of brain atrophy. He's even got a bit of hydrocephalus, having difficulty walking, having some cognitive difficulty. This is neurotoxicity. And in this case, it was neurotoxicity from the whole brain radiation. The risk factors are well known. Age, older than the age of 60, clearly a risk factor. Any regimen that contains whole brain radiation. And the clinical domains that are most commonly involved are listed here. And our IPCG group has created a targeted battery to look at these particular domains in assessment of these patients. Now, my clock is blinking here, but I thought that it was 25 minutes?
You're okay.
Okay, all right. I'm in the red zone, according to my... yeah. All right, so just one more slide on neurotoxicity. So these are a couple of small studies, but I think they're important. This is a study of 80 patients who achieved complete remission by various means. Some of them received only chemotherapy, some of them received chemotherapy and radiation. This was not a randomized trial. But the good thing, the nice thing about this study, there was comprehensive prospective neuropsych, quality of life and MRI assessments. The median time of follow-up was not that long, about 2.5 years. But what they showed is if you look at neuropsychological testing, those patients who had received the radiation had a drop-off, a significant drop-off in a number of different cognitive domains that you see listed here, versus the patients who received only chemotherapy. The other study is a small study, 19 patients in remission. These patients had received only chemotherapy alone. And the reason I included is this study also had, again, comprehensive assessment, neuropsych, QOL, and a median follow-up of over 8 years. And in these patients who had received only chemotherapy, all of them were living independently. Almost half were working in the same capacity, a job, as they were before their diagnosis, and there had been no decline in 6 out of the 7 neuropsychological domains over time, implicating, again, radiation as a major factor in this neurotoxicity problem. It is clearly not the only factor, because patients receiving chemotherapy can also develop it, but clearly it looks like it's at a lower incidence than those who receive radiation. So this has led the field really to look at lowering the dose of whole brain radiation or trying to eliminate whole brain radiation. So this is a study, a multi-center phase 2 trial, where they reduced the dose of whole brain radiation. This was the group out of Memorial. About 50 patients, the median age was 60. They used their regimen, the so-called RMPV regimen. All these regimens are built around methotrexate, rituximab, methotrexate, procarbazine, vincristine. After induction, they received whole brain radiation, but at a reduced dose, 23 gray versus the normal 36 or 45 gray if you had a CR. They then went on to receive ARC. 60% of their patients achieved a CR. Their 2-year progression-free survival, about 80%, which is quite good. Median overall survival, about 7 years. Certainly not as good as mantle cell and follicular, but in our disease, this is pretty good. And there was neuropsychological testing, and it's described in the paper as relatively stable, but it's early yet, and we really have to see what will happen over time in this population treated with this reduced dose of whole brain radiation. I confess that I'm a skeptic, because if you look at preclinical data, animal models, single fractions of radiation can really significantly damage neuroprogenitor cell populations in the brain. So it's hard for me to imagine that you're going to get away even with a reduced dose of whole brain radiation in the long term, but we shall see. All right, so this was the study that asked the question, can we eliminate whole brain radiation? So this was published a few years ago now in Lancet Oncology. This study was done in Germany. It's the largest study ever conducted. Over 500 patients enrolled in the study. However, there are a lot of protocol violations. The chemotherapy was switched about halfway through. They switched from methotrexate alone to methotrexate plus ifosfamide. So there are some methodological flaws, no doubt, in this study. Nevertheless, they looked at in the intent to treat group. Clearly, there was in the whole brain radiation, it extends progression-free survival in this group. But if you look at the overall survival between the radiation versus chemotherapy group, there is no difference. So again, extension of progression-free survival by having whole brain, but no difference in overall survival. Again, this study has been the subject of a lot of criticism, but I think that there is some kernel of truth to what they're seeing here. And this has led, again, other groups to look at other approaches that defer radiation, use it only at the time of relapse. So this is another multi-center phase 2 study. This was done in the CALGB, or now the Alliance. And in this regimen, James Rubenstein's study, this was using methotrexate, temozolomide, and rituximab, so-called MTR chemotherapy as induction. And in this case, they went on to receive consolidation with etoposide and Ara-C. And 46 patients, so a small study, but 60% complete responses to MTR induction. Median PFS, about 2.5 years, and the median overall survival had not been reached. Estimated 4-year overall survival, though, at about 65%. So these are encouraging outcomes, and this serves as the foundation for a randomized trial that has been launched in Alliance, and I'll come back to that in just a moment. Now, this is a paper that just went online within the last 48 hours in the JCO. And I show it. It's a combined modality regimen, so it's radiation and chemotherapy. But I show you this because they use the MTR regimen, which I just mentioned to you, methotrexate, temozolomide, and rituximab. And again, this is in a multi-center setting, seeing a 50% CR, about an 85% overall response proportion just to the MTR regimen. So I think this is an active regimen. We can certainly do better, but it seems to be holding its own against other more complicated toxic regimens that are being used. And in fact, the investigators in this trial said this is the best 2-year overall in PFS achieved in any RTOG PCNSL trial using more complicated chemotherapy regimens. So a word about high-dose chemotherapy as consolidation. So much of this original work was out of France and Germany. This is Gerald Illerhaus's work in Freiburg. This is a multi-center study, about 79 patients enrolled. As you can see, the median age a little younger because these patients had to be eligible for a transplant. In this case, the induction was the matrix regimen, again, the methotrexate-based regimen. And in this case, patients were consolidated with high-dose chemotherapy and an auto transplant. And the conditioning drugs were BCNU and thiotepa. And the 1 and 2 years early yet, but the 1 and 2 year overall survival about 90% each. So this is encouraging, although it's very early. Looking at his institutional experience in Freiburg, over 100 patients now transplanted, the median progression-free survival 85 months and the median overall survival 121 months. Now, that's not a prospective study. That's putting a lot of patients together retrospectively, but this is a promising approach, and for patients who are transplant eligible, many of us are moving in this direction, and it has encouraged a number of randomized trials that are asking this question: what is the optimal consolidation? A transplant versus something else. That something else could be radiation, that something else could be some other type of chemotherapy. What about elderly patients with primary CNS lymphoma? Again, the median age at diagnosis is 60. And this was a trial. We want to avoid whole brain radiation in these patients. Most of these patients are not going to be eligible for a transplant. So this was a randomized phase 2 trial done in France. And the patients were randomized to receive two types of chemotherapy. The old RTOG regimen, or the memorial regimen, which is methotrexate, procarbazine, vincristine, and ARC. This was before rituximab was incorporated in these regimens. And this is methotrexate and temozolomide alone. These are the results. So randomized phase 2, 98 patients. Median age of the patients, 72. Although the trends favored MPV ARC over the more simple, less toxic methotrexate temozolomide regimen, these did not reach statistical significance. And there were no statistically significant differences in the response rate or the overall survival either. So whether or not the extra toxicity is really worth it with the MPV regimen remains a question. How do we follow these patients after they've completed the therapy, hopefully in CR? I won't go through these in detail. Again, it's out of these 2 papers that the IPCG published. There's a schedule of MRI scans, eye examination, CSF examination. Again, I would highlight that it's important to keep track of cognitive function of these patients if you can. That's a very important endpoint in this disease. As I mentioned earlier, we are in the era of randomized trials. Even though most are randomized phase 2, we've had 4 completed trials and 5 that are ongoing. Even 15 or 20 years ago, we had virtually no randomized trials in this disease, so I think there's some progress there. Just a word or two on novel therapies. We are clearly behind the curve here. There have been some very small studies using drugs like pemetrexed, which is active, but has not a great progression-free survival. But again, this is in relapse refractory disease. Lenalidomide, anecdotal experience, really. 1 publication here. At Lugano last year, there were 8 patients with primary CNS lymphoma relapsed or refractory treated with lenalidomide. All 8 had responses. 4 were complete responses. So that study moves along. So the drug clearly has some activity in primary CNS lymphoma. This was just published last month. Temsirolimus, the mTORC inhibitor, about 37 relapse refractory patients. Again, overall response rate not bad, but progression-free survival quite short. So clearly this would have to be combined. And this is an interesting regimen really developed by Wyndham Wilson and Kieran Dunleavy at NCI, and they're really targeting the ABC subtype of CNS diffuse large B-cell lymphoma, which again, almost all of them are ABC subtype. And the regimen is really built to target ABC, but also to choose drugs that can get into the nervous system. And you'll notice here that ibrutinib is part of the regimen. And if you look at this table, the first couple of patients, so I lost my pointer, But you can see that with ibrutinib, they did CSF assessments after giving ibrutinib. About 25% relative to the plasma ends up in the CSF. So the drug does have some CSF, CNS penetration, and some of these patients have had responses. This was presented at ASH over in 2014. This has been updated. They're up to 15 to 20 patients yet, but I couldn't find an updated publication. But they're seeing the same thing with this appearing to be an active regimen. So in summary, this is an uncommon subtype of non-Hodgkin lymphoma. When it occurs in the brain, non-Hodgkin lymphoma almost always is diffuse large B-cell and of the ABC subtype. I didn't mention it, but there really is no role for surgical resection in this disease. The role of your neurosurgeon is to do a biopsy and make a diagnosis. Whole brain radiation alone is palliative and associated with some clinical neurotoxicity, especially in patients over the age of 60. Methotrexate-based chemotherapy is what we would consider right now the standard induction. And you can really choose your dealer's choice in the regimen that you use. Some of them are listed there. We have not yet defined an optimal consolidation treatment. Several options are in the mix, including transplant, reduced dose whole brain radiation, or other types of chemotherapy. And clearly, development of novel agents in primary CNS lymphoma is lagging behind our colleagues in systemic disease, but we're trying to make some inroads there as well. Thank you very much.